15. It is hard for me to believe that we are already on number 15. It's also very exciting to have the opportunity to talk with you all again today with an exciting conversation topic, interprofessional collaboration, near and dear to all of our hearts, something that I think all of us deal with on a day-to-day basis, even if we don't absolutely 100% of the time call it that. It's definitely a opportunity and a challenge that comes up on a routine and regular basis. I want to say a quick thank you to our presenters today for joining us, our folks from Family Voices National, whom you are all very familiar with, Kara Coleman and Mary Jo Palladino, and also two of our National Advisory Committee members, Gary Naritz and Renee Turchi, who were kind enough to join us today as respondents and participants, expert participants on today's webinar. We also have presentations by Team Colorado and Team Texas. So you will have the opportunity for some peer-to-peer learning and information and networking. And last but not least is Steve Fitton, who, as you all know, is our liaison to the world of Medicaid and an expert in that area. We're very grateful to him for joining us as well. As you may recall from January's webinar, we are continuing to test a new format for our webinars. This means it's a jam-packed agenda with a lot of different voices and a lot of different moving pieces to coordinate. But we feel confident that we have put together a good quality and high value webinar for you all today. I would like to very much encourage you on behalf of both myself and the entire BU team to please, please, please fill out the evaluation at the end of the webinar, because as we just mentioned, we're testing this new format and we want to make sure that it's working for you. And if it's going well, we want to continue it and make it even better. So with that, let's go ahead and switch to the next slide, please. This is our usual housekeeping. As you all know, the webinar is being recorded. I don't currently see the little blinking recording button, so let's go ahead and switch that guy on. Anything that you say can and may be used against you in the court of public opinion, so watch what you say on the webinar. Just kidding. Candor and transparency is important. Please don't use your speakerphone. Please try to use either a handheld landline or your computer speakers to talk with us. Please don't put us on hold. Please mute your phone when you're not speaking. You can either use the mute function on your phone. You can press *6 to mute yourself or *6 to unmute yourself if you don't have a mute button on your phone, or you can mute your computer speakers on your computer screen. And you should find that mute button down in the lower left-hand side of your Zoom screen. Participation is, as always, essential, so please either speak up verbally if you have questions or comments, or use the chat box in order to get into the queue to speak up or share a question or a comment. As you all will recall, we are able to automatically save the transcript from our chat box, and so anything you say is recorded for posterity, and so it's a really great way for us to be able to keep records and keep notes and keep track of the wonderful things that you all have to share that we might not get a chance to cover in the webinar itself. So you can link your phone with your computer, which is helpful to us when we're trying to figure out who's speaking when and if we need to manually mute people ourselves. So if you could go ahead and link your phone with your computer, we're going to change the slide now and just show you a quick graphic on how to do that. If you join by computer after calling in via the phone, you enter your participant ID, and the directions are here on top of, excuse me, at the bottom of this slide. Your participant ID usually pops up for easy access on the webinar platform, but you can also find it under Join Audio if it does not. Okay, let's go ahead and switch to the next slide. I'm going to turn it over to Bethlyn now, who has done the overwhelming majority of the work in leading the agenda for this webinar. And I want to say thank you to her and congratulations in advance. I'm super excited about this. So take it away, Bethlyn, with the agenda.
Thank you, Meg, and welcome everyone. Really appreciate your joining. So as you saw, we, once again, with this new model of a shared learning lab, we are really trying to have a host of individuals from different key stakeholder groups and available resources and expertise all in one place, including your peers, so that we can really meet you at point of need with the things that you're grappling with within implementation phase. So that's what we're working to do with this agenda, and I'm going to try to keep us on time. It does end up feeling packed. We tried to be aware of creating a little more room compared to the first time we did this model, but part of it is actually intentional that we try to bring in a bunch of different aspects to this so that you can then pick and choose what you might want to continue following up on, either with your coaches, with us, so that this is just kind of a seeds of a conversation for you that might help move you forward in various areas where you chose. So interprofessional collaboration was a choice, a top priority from the state teams in surveys with you. So we were being responsive to that. So when we just want to be clear in saying that interprofessional collaboration, we speak to that for the sake of this webinar and just for the sake of the CoIIN in general. We're using that term, and we're using that term in a broad way. So it's both within and across settings. So it might be within a system of care, but would also be across settings between, so it might be clinician to clinician, but it could also be with other team members towards integration, like with social workers, for instance, or that it could also be other settings such as with a family leader, with Title V, with Medicaid. So we're looking in the spheres of structural, operational, but also policy and financing. So just to have that in mind, you'll see that we're gonna start with, we're right now doing this intro. Then we're going to move into the FESAP. You all did such an excellent job with your FESAP process, and it provides we started with that because it provides an operationalization. I'm so bad with that word. It operationalizes interprofessional collaboration at the systems level. So with using families as practitioners and partners. So having that structured but efficient process that you've now all taken part in and experienced within your teams to assess collaboration using concrete measures, that just sets everyone up for a clear plan for prioritized, focused improvement and progress. So we thought that would be a nice place to start when we're looking at this, and then move into other forms of interprofessional collaboration, which just aren't as structured as the FESAP process has been, as Family Voices work has allowed us to have with the FESAP process, but that can be carried through into consideration of that. So I guess that's really all I have to say on that. So first we're going to do some updates on the project. So I'm going to hand it back to Meg, and then we'll be ready to go with the into the next section of the FESAP. So the next set of slides, and Meg.
Thank you. So starting with the AMCHIP conference, as you all know, it's March 21st through the 24th in Washington, D.C. There are many state teams and CoIIN faculty who are going to be presenting on various aspects of the CoIIN work. We do have a specific session that I am recalling off the top of my head is on the day of the conference, and it is at 3 o'clock in the afternoon. Is that correct? East Coast time? Don't take my word for it right now. Just know it's Monday afternoon. It's one of the workshop sessions, and it's specific around Title V collaboration in the CoIIN, and we're really excited about that. I know that the folks who are presenting on that panel have been working really, really hard, and they've got some really high value material to share. So hopefully if you're there at the AMCHIP conference, you'll be able to join us for that session. Don't go to the competition, come to us. You all will be very excited to hear, if you haven't already, that our carryover funding has been approved, with sincere thanks to our colleagues at HRSA for working with us on that. It's currently in the process of being looked at and reviewed, and contract amendments are being issued by Boston University. As you all know, Boston University is a large institution with multiple layers of bureaucracy. There are about 457 rungs on the food chain at Boston University, so these things take some time, but we are working on your carryover now. I had a couple questions come back to us for a couple of states, and so if you've had a question that's come up, you've already received that information. I know that folks are working on that, but subcontract amendments for carryover are being processed now. The final round of your 3 subcontracts are currently being processed as well. So that is on its way. Thank you all very much for your patience with all of this bureaucratic process. Very important stuff, but also a little frustrating sometimes with the length of time that it takes. But we acknowledge that and we appreciate your patience. In terms of 2020 consultation visits, they are going to start in May. We have all 10 states scheduled between May and September of this year. The consultation visits are scheduled to start in May for some states. Your IP coach will be working with you soon to start planning the agenda for these visits. There is a possibility that we may need to do consultation visits remotely this year, depending on how the situation works out with COVID-19, but we will definitely keep you posted on our thinking around that. If you have any feedback for us, please don't hesitate to let us know, or any questions. We very much appreciate the opportunity to think through this with you and make sure that our plans are in alignment with your needs. With that, I'm going to turn it over to Bethlyn. Excuse me, I'm sorry. I'm going to turn it over to Kara Coleman and Mary Jo Palladino, who will be presenting on interprofessional collaboration.
Good afternoon, everyone. Thanks for joining us this afternoon in our little section here on the FESAT. I'm going to let Mary Jo start us off here. If Libby, you can turn to the next slide. Thanks. Mary Jo, are you off mute?
Mary Jo called in through the phone, so let me see if I can find her on here.
We just need to know her phone number.
Yeah.
It's 5, I'm just looking at the area code, sorry. It's like 547 or 574. Sorry, guys.
Mary Jo, can you try speaking again? I unmuted all the phone numbers, so.
Okay. All right, well, I'll start in on Mary Jo's part, and then Mary Jo, if you're able to call in and speak, just please interrupt me, because your words on this slide are much more eloquent than mine. But what we're trying to do here is just identify some themes that we saw sort of across all the CoIIN. Hopefully you guys have gotten emails that were sent by myself, but that's on behalf of myself and Mary Jo, and then Glenn Gabbard, who I'll talk about again in a few minutes, who's joined our Family Voices staff in the CoIIN. So hopefully you got that, and we'll talk about that some on the next slide and sort of our ideas of ways to help move your action plans forward. But with this slide, what we were thinking is, you know, in looking through everybody's scores and all your hard work in the process to do assessment and in your process to make really tremendous, thoughtful action plans, we looked at each of the domains: the domain of commitment, the domain of transparency, the domain of representation, the domain of impact, and just tried to identify, based on scores and action planning, what are some of the themes across all state teams that we are seeing. And so that's what this slide represents, that you know, some people identified, some teams identified that they had a written policy of family engagement and others didn't. Do you have to have one? Who knows? Does it matter? It doesn't make a difference to have things written down. In some respects it does, because if you're looking across all the domains, if you're sitting down and writing what is, and really thinking about what is our policy of family engagement, what does it mean to us, and then you're writing it down, you're sort of committing to it and being transparent, and then working on representation and impact. It's sort of what you're doing really by doing this wonderful assessment of yourselves and your work together in improving family engagement. So that was something we sort of saw woven throughout everyone's work thus far, that you may not exactly have already had it, but you're doing it and you're moving forward, and it's part of the process, and it's really great. Some of the other themes we saw around transparency were that people were really kind of grappling with what support is needed to understand how to work together and what your respective roles are in partnership. And then also looking at what information is really needed to help people participate and partner more fully. And that's for not only the families, the family advisors, the family leaders, family, whatever, you know, title or whatever you're calling the families involved, but also for all the different types of professionals, the interprofessionals, all of us together as an interprofessional team, what types of supports are we needing to understand how to work together more fully? And within the representation across all the state teams, there was a lot of grappling with, are we representing all of our CMC and CMC families and professionals and everyone really fully? And how do we get to that? So that was definitely a theme across. How do we recruit and work with more diverse and, you know, broadly defining diverse families? And then impact, a lot of teams were looking at how can we include family and family leader input, not just, you know, invite them for participation or get some information here and there or advice, but really include in an inclusive way. So with that, let's move along to the next slide. Yeah.
This is Stefan. I just want to let you know that Mary Jo, I see her on. Mary Jo, can we hear you? Want to say something?
Can you hear me now?
Yes. Welcome, Mary Jo. I just butchered
Okay,
your
thank you
slide
for doing the slide. Thank you for doing that.
Yeah. Do you have anything to add? Do you have anything to add what I said that you want to tie it up with a neater bow, please?
No, excellent.
Okay, great.
I think we can jump into the actions.
Okay, let's jump into the actions, and I don't want to delay the lovely Angie Goodger sharing about Team Colorado, so I will breeze through this slide. Here, I was just trying to come up with a little bit of a representation of what we tried to capture in the emails that we sent to you guys. We were just trying to offer some tangible ideas in response to some of your scoring and some of your action plans and some of the things you wanted to work on, or that we saw maybe some tools that might help you work on some things. And a little about, we pulled activities, rubrics, ideas, all kinds of things, tools from, of course, the FESAT resource toolkit, but also 2 trainings that I think we've mentioned before, Serving on Groups, which is really designed to help prepare families or those who may not have a lot of experience serving on all different types of groups. And then also Leading by Convening, which is put out by the National Center for Systemic Improvement. And this training can be done in parts and whole, and most of you guys received links to the larger training, and then some of you received links to very specific activities. But I just wanted to give a quick kind of overview of what Leading by Convening is doing, and I think it's so apropos to be talking about it on this webinar where we're also talking about interprofessional collaboration, because Leading by Convening is really about how to get families, professionals, interprofessionals, all of us together to do work. And it's focusing and allowing you to drill down into sort of the habits of interaction that are either present or not quite present and emerging, or maybe that we need to take time to put into our daily professional and personal lives to really bring people together. And those habits of interaction allow teams to do work together, ensure relevant participation of everyone on the team, and then also coalesce around issues. And I love the definition of coalescing around issues. It's about demanding an exploration of the issue from the perspective of the implementers and the stakeholders. So really, that's, to me, the essence of what the CoIIN is moving at such a rapid, high pressure pace, especially now that we're in implementation phase, but there's so much too in the collaboration aspects of CoIIN that allow us to take that deeper dive and demands that we look deeper for our kids with medical complexity and families. What is going on, and what for everyone and the professionals and all the professionals, how do we come together on this? It's not just making a plan or training, but really diving deeper into the issues. So on the transparency domain, there was quite a few action plans that had to do with how do we understand each other better? How do we work together? better. And then also for some teams, it's how do we refocus how we're working together and how we're looking at family engagement. And then others, we've got to get other people to buy into what we're doing here. And so how do we brand this great engagement and partnership that we're working on? One of the tools that I sent around is called What's in It for Me. And it's an activity that allows people to, create professional and personal value, and looking at what does it mean to participate and what does it mean to be involved, and how can you identify strategies, like simple strategies with how you, run a meeting, that either help people identify, is someone just participating, are they just present, or how do they become more involved? And then around representation, the ideas that we had, there's some little tools and stuff that we shared, but also, we wanted for all teams, I'm not sure we put it in the email, but for all teams, since we have Glenn Gabbard on board now, and he has a tremendous history and work history prior to coming to Family Voices, as a researcher, working with diverse populations, as a diverse family leader himself. He's leading Family Voices work with the Pacific Islanders and the Native American communities, that he is willing to take any time and way that it helps you guys work on how do we recruit and engage and work with more diverse communities, and however you're defining diversity. And so the other way that we reached out to you guys with impact was around data. I sent around some ideas of from serving on groups of how you prepare families to work with data. For people who haven't maybe worked with quantitative data or qualitative data yet, how do you gather it? How do you use it? How do you train family leaders or families to do it and to interpret? One of the teams in particular is really working on the evaluation aspect and engaging family leaders in their evaluation. And so there's some really great tools that have to do with taking qualitative data, which we all know the focus groups were so rich in, and all of our work around coming up with the focus group questions as well, and how do you move it into quantitative comparisons and stuff. So there's some tools that we sent around for that. So I will hand it off to Angie for her wonderful sharing about the very thoughtful process that Colorado came.
Sarah, just before
yeah.
we do that, sorry, Angie, I just want to jump in and say that Tricia Brisbane was asking if you could share the leading by convening links, if you could drop those into the chat perhaps.
Well, I can most definitely attempt to do so. If not, I will call on the lovely Libby to assist me in that. Yes.
All right,
we can also make sure to include those in the follow-up email.
Okay.
Great. Thanks, everybody.
Yeah,
And
take it away, Angie.
Great. Hello, everybody. I would say good morning, still morning in Colorado, snowy Colorado. Go ahead and go to the next slide for me, please, Libby or Bethany. Thanks. So our process, I am representing for our team today. I think others from Children's Hospital had another meeting this morning, but really has centered around that establishing an action team from our advisory team to not only complete the CSAT, but negotiate our scoring and selecting strategies. We worked to make sure that we had really good representation from all groups. And so whether it was, who completed the CSAT tool or those that have been on our action team, we've had really great representation, especially from our family representatives. We've met a couple of times with that group, and then a smaller work group has been looking at, what are our potential interventions and what might that look like if we were to, not if, but when we completed our action plan. Ultimately, we did select 2 domains, and from those domains drafted what the outcomes were that we were looking for. And we used the CSAT resource toolkit to outline what our strategies might look like. You can go to the next slide. Thank you. So you can see that our main domain ended up being domain 1 around commitment. One of the things that we were really trying to focus on was working to align and build upon the work that we're already doing. So it's really easy for our team, maybe others have found this as well, that sometimes that we get excited and we have all these ideas and our scope keeps expanding farther and farther. And so we kept asking the why questions and moving it back and really to see how do we align what we're seeing within the scoring to also support the work that we're doing with the rest of our project as well. And one of those things we were really excited about is that as we did work through the process, we found that we were actually sort of validated in the other ideas that our advisory team, which includes our family representatives, had already been discussing. And we had a lot of conversations around sustainability and growing that group so that it's not just done when our project is done, but that it would continue going forward. And so we were excited just to see that, okay, our ideas are validated. Now, where do we want to start? How do we, where do we start? And then how do we build on that? And going forward to sort of get closer and closer to that big vision that our team had. And then implementing, figuring out what does that plan look like. Next slide. So our second domain ended up being domain 3, and we actually saw a lot of tie-ins between commitment and representation. And so we wanted to figure out a way to blend and weave those together as we move forward with our plan. So again, our action team was working together to finalize different concepts and outline potential strategies and action steps. And we brought those back to our advisory team to review and kind of start testing the feasibility. We also had to ask for an extension of time to make sure that we were able to meaningfully engage our families and partners. I think that that's one of the things, it takes time. We have really big systems and people coming from a lot of different places. And so we were thankful to have some extra time to be able to thoughtfully approach and make sure people were able to participate in the process. Next slide. And I know some of these are hard to see. I just wanted to give an idea, though, of what we were looking at. So, so from those two domains, what we landed on is that for outcomes, we really wanted to see that our special care clinic, which is one small piece, big piece, small, I don't know what they would call themselves, but they're one piece of the children's hospital system. And so we wanted to start there and ensure that we had a value statement regarding routine and consistent engagement of families with their clinic design, any of their change improvement strategies. And we wanted to see it created, but then also implemented within the special care clinic. And then also in order to do that and to continue building on that, we felt that both families and staff really need to understand their role and are able to participate fully in the process as we go forward. So as you can see here, our strategies, we feel like those are really enabling us to leverage our work. As an example, we found that from our first family survey results that there were several words that our family reps and providers felt could use some definitions. The providers would like to know how to improve those scores. They weren't happy with the initial round, and so they wanted to know how do they talk about those concepts, and would families want to talk about those concepts? How would they want to talk about those concepts? And so I think a couple of the words were well-being and meaningful life, and so we felt that even right there was an example of how we could start to figure out how do we work differently together, how do we talk about some of these different pieces, and then what does that look like, you know, in day-to-day, but also when we come together in advisory groups as well. Another example that we felt was leveraging we've had a lot of ideas, I think ever since we were in Chicago last fall, actually, around, you know, would we want to do a support group? Do we want to do more focus groups? How do we involve families in the future special care clinic QI efforts? But we also knew that we wanted to be able to recruit and engage and develop those family leaders so that they could be prepared. So what we decided from that is that while we're also recruiting and preparing families, we really need to build awareness and desire of the special care clinic team and members and leadership. And so in starting with our value statement, we really felt that we could work those different groups together to have input, and then hopefully make that go live and move towards identifying when, where, and how you can actually live that value statement. So as we go forward, developing a menu of strategies that people understand and are comfortable with and confident in. So this was our very brief action plan that we shared, because there's still a lot of in between there that we are trying to figure out and to design. Next slide. Again, I know you can't read it, but I wanted us to speak to the complexity of just the work within the systems. And so our categories, we've got outcome strategies, potential activities, metrics, who's responsible, who can help, what's our timeline, when do we want to have it completed by, document links. So, you know, if we're planning something, do we have a document and can we link to it all from one place? Resources, notes, etc. So as we work within the system and me alongside the system, because as a reminder, I'm at the health department, and so I'm limited to what I can have access to within Children's Hospital. This was a tool we've been working on to develop and really figure out, you know, how do we keep things organized? How do we keep people on task? How do we work through and identify potential benchmarks and metrics and ensure the feasibility to meet our long-term goals? And then how do we divide and conquer? So we've worked to identify what is internal that Ellen really needs to have oversight for, what can be external that I can have oversight for. But then even if we're a lead on those things, who else is responsible and who can help as needed? And so if you could read the screenshot that I did there, you would see that we have family leaders who have responsibility. We also, who have stepped up, who said they want that responsibility, which is really fun from my perspective as well. And so you'll see that we have that and we've just split it up, but then also knowing that we don't have to, nobody has to be in it alone as well. Over the next several months, what we're really working on is making sure that that these activities are going to be feasible, setting our timelines and benchmarks so that we can really move through those strategies. And then our site visit takes place in late August, and so we're really trying to work to align. We've got some training opportunities that we've built in that we hope that if we can move through some of these activities, we'll have identified training opportunities and maybe could use part of our time that we're pulling everyone together in August to do, to address some of the training that we've identified. And then I added one more slide if you want to go to the next slide as well. And I don't know if I was supposed to do this or not. So, but I think that some of the questions that continue to just come to my mind, again, just this idea about it's so easy to keep dreaming and coming up with these cool new ideas and projects. But to quickly evaluate and prioritize and really keep our focus so that the things that we're doing continue to build in ways that everybody can see that and can understand that those little steps in between help us really get to our long-term vision. And then also, you know, how do we encourage ourselves to just do it? I think we have this temptation to wait for perfection and complete buy-in before we're trying something that might be new. So, you know, the idea of perfectly imperfect and just jump in and see, especially in things that, you know, we can just try it and kind of keep moving it forward. So, and so apologies, Bethlehem, if that was for a different set of slides that we were working on, but I thought I would just put those in there as well. And hopefully, if there's anything I missed that you wanted me to talk about.
I think you just did great. I'd love to see, to let Kara and Mary Jo take it on as facilitation. I think that's a great foundation for just kind of conversation amongst the group for kind of shared learning lab. So take it away, Kara, Mary Jo, and any questions for Angie or thoughts or feedback. Go ahead.
Yeah, no, this is Kara. Angie, that was such a wonderful presentation or sharing. And I absolutely love the questions that you came up with. And because I had written down the notes too, of that you guys did the hard work asking yourself the why questions, like how do we align the scores with the rest of our project work, but also advance the field and really push sort of our limits, but keep it focused. So it's along the lines with some of the questions you have here. So I'll open it up to anyone else. This is a time we have like 10 minutes or so, a little bit less now, where we're just kind of sharing, either asking questions to Angie or asking of each other, or going to some of the pre-work stuff that you thought about around your FESAT experience and stuff moving forward. So fire away.
This is Mary Jo.
Yeah, go ahead,
This is Mary Jo. I wanted to add a couple comments. It was really interesting, Angie and team, how you use the FESAT scoring tool, the Excel sheet. Your documentation is just very interesting and I think can be very helpful for you at the stages of implementation and future actions. Just even your notes on your consensus scoring and why you may have rounded down or up, I think will be really helpful in informing future action and steps. Also, the recording of perspective at this point in time, as future assessments are done, I think that that'll be really helpful in informing. And again, back to answering that question of why things are done, I think that that data may be very useful to inform the why in your future action plans and steps. And again, you pointed out identifying lots of things you want to do, but how do you prioritize to get it done? But capturing the documentation of it and then prioritizing, you won't lose anything. In addition, maybe we could go back to the two other questions. Are there others that have suggestions or comments?
You can just chime in, chat it, raise your hand on these questions or any others, or thoughts, or sharing progress, challenges, or successes with your own plans and moving them forward.
Hi, this is Bethlen. I guess one thing, I think if, Angie, can you tell us a little of how, like the idea of focusing and figuring out getting everyone together in the time, those kinds of things. Can you tell us a little more of your process for that? Like, so we can get some tangible strategies for that within each team, because I imagine that those, you're not alone in those being some of the challenges.
I'm sorry, as far as getting people together and needing a little bit more time to be able to do that, or?
I think, so two things here is, one is in relation to kind of the, maybe start with how you ended up really deciding how you're going to focus, because I'm sure there are different, to get to consensus around that and decide how to really focus in, because we all want to kind of do a lot of things.
Oh, yeah. So, well, one of the things that we did is we with our inviting in who would complete the VSAT, so we found that we have a lot of, like children's staff at the table a lot of times for our advisory team, and the balance, sometimes there's a power differential there. And so what we did was we were really intentional about making sure that we had representation from all the groups. So we had providers, specialists, we had community providers, we had family reps, we had a care coordinator or two. And then just to balance that out a little bit. And then for our action team, I think we ended up pretty much having, for everybody who's part of like the CoIIN and who's employed by the state or the hospital, there was a family member, I think for all those meetings that was there kind of as their counter, as the counter person to that person. So we just worked really hard to make sure that we had that type of engagement. And then because of all the different people, we had to it took a while to find some dates where we could ensure that we kept that balance for those meetings. And so, you know, they were evening meetings that we had, and really then also allowed for people to say if, you know, they wanted to negotiate and talk it through, but they didn't want to be a part of the planning, that was also okay. And so we did that. And then from the, I think what Mary Jo was talking about with negotiating through the different ideas, we looked at our scores and we prioritized either the scores that were most, that were lower, or the scores that people wanted to talk about the most. And we started there, and that meant in some cases with the different, if you go back, I don't remember what they're called. Can you back up the screen to a couple of, two more maybe? So how for, like, we had each of these under the domain, we had the different concepts. And so some of those we may or may not have even talked about once we had worked together to identify where do we want to start within this. And then what we did is we took notes. And so when family members either liked something or were concerned about it, we made a note of it. Same with providers and other team members. We also went back through all of our previous meetings and found alignment where did we talk about that concept before? What had we talked about at that point? So it took us a little bit longer, but I think we still kept it to 2 hour-and-a-half meetings in order to get to some level of consensus. And I think as we talked it through, people felt pretty good about where we landed and how we landed. And of course, then we talked a lot about not taking on too much, but then also seeing the connection between the two domains and trying to figure out how we weave them through. So I think, does that kind of get to what you were wanting to hear?
Yes, I think more of the mechanics. Yeah, they're helpful.
Does anyone have any questions based on what Angie just shared? Or if not, I think we might move. Libby, if you can go forward a little bit, we're going to bring out our trusty wheel to see if we can get a little sharing about the FESAT. So if you can spin away, that would be great. Alabama. Is anyone on the webinar today from Alabama that would like to ask questions about what Angie shared, or share any of your pre-work sort of thinking about surprises you had with FESAT, challenges you're grappling with, any new partners around your FESAT action planning that have arisen? Now is your time to shine. You may need to unmute yourself. Alabama? All right. Well, Alabama does not seem to be in the house for any FESAT. I was trying to think of the Louis B. Armstrong's song where the stars fell on Alabama, but that probably would make them run and hide rather than come out. So, all right, Libby, could you spin her again, please? Washington, the fair state of Washington on the West Coast. Is there anything that you could contribute? Oh, no, wait a minute. Hold on. Before we go to you in Washington, Stacy, there you are from Alabama. Uh-oh, she tried talking, but you couldn't hear. I don't know, Ben, if you can check the whole muting or unmuting issue.
So I'm looking.
Yeah, it says that your name doesn't have a microphone or phone connected to it. I don't know if you called in with a separate number. I could unmute your number. Oh, yeah.
Stacy, can you give us your number so we can unmute it for you?
Yeah, like the last 4 digits would be great.
All right, well, while she's doing that, maybe Stacy, if you could chat the last 4 digits of your cell into the chat box, Ben can help unmute you.
She doesn't know her number.
Uh-oh, okay.
Oh.
All right, well, Washington, is there anything that you can share with us about your FESAT process or questions or stuff you're grappling and working through with your roadmap and family engagement?
So this is Jill. Can you hear me?
Yeah, welcome.
Yes.
Jill.
Hi, sorry. I'm in the car, so you're going to hear car noise. I apologize. I think that any grappling that we had with the process of FESAT was just how our team is made up, so that kind of the state systems folks are very engaged in what we're doing, but the process delivery team is the family lead, the family navigators, and Seattle Children's and Seattle Children Navigators. So I think the challenge was getting everybody to see the process and to see how decisions were made and to see how work moved forward, with the family engagement component being just so intrinsically a part of the process of the work itself. And so that's where we are like going, oh, how do we do this? How do we bring everybody together at the table kind of at the same level so that we can all look at that? And then how do we look at moving that forward with our families as they start to kind of growing into being a family? And how do we get them to that next step beyond just trying to survive, to look ahead and understand that they, moving forward, can have a voice in their child's care, and then beyond that, in their community. How do they build a community, and then how do they understand that they have a strong voice in their community? Did that make sense?
Yeah, it did. It's wonderful sharing, and it's so layered. You know, and I love your graphic in Washington of the roadmap, and I felt like we were just traveling down the FESAT roadmap with you as well and sharing that. And I think it actually lends itself to a good segue to the next part of the webinar, Bethlyn, if that's okay with you. But just, I'm so struck by what you just shared, Jill, and by what Angie shared, that, you know, the FESAT is, you know, about helping, you know, you guys as CoIIN teams, but also whoever else is utilizing the FESAT tool to measure, well, not measure, big misuse of the word, assess, not measure. Yes, assess, you know, family engagement. But what I heard in Colorado's presentation, and just from you now too, Jill, is that really taking the time, and it does take time, and that is very challenging, but taking the time to do a FESAT assessment helps bring all the parties to the table and figure out who are the parties and what does everyone need to be able to move forward together and get on that same page. And I think that, you know, doing a FESAT assessment is really, you know, leading by convening and coalescing around issues together. And so it's lovely to hear that, yes, it's about families and how we move that partnership forward, but it's about how we move our interprofessional collaboration and partnership forward for everyone. So with that, thank you again so much to Angie and for Jill for being called on and rising to the occasion. And I will hand over to Bethlyn to lead us into the next section.
Yes, thank you. Of course, this was just meant to be just get the thoughts brewing. I don't know if there's any, we're going to move into the next section. If there are any last moment comments before we do that from anyone, you're welcome to chat them too if you have any thoughts. Okay. So I think that was really perfect, Kara. So I do just want to say what we're trying to do is if there's anything that things that you're grappling with for your team, we'd love to just have you type in what kind of the thing that you're at this moment has been the thing that you're grappling with and considering, because then we can use that to help us to pull together for all the teams to see. And I think sometimes that's just very helpful for everyone. So just as a note, and what we wanted to do the FESAT first because it really does create a structure for moving everything forward. So now we want to move into considering the diverse range of interprofessional collaborations and thinking of this towards sustainability in the CMC CoIIN, because so much of this is about getting everyone on the same page and including both in the same setting and external settings. And this project in particular requires that you have a diverse set of collaborators and stakeholders on your core teams. And we're going to be really engaging with this further. So to start us out, we have Team Texas, and we have Dr. Grahani on the line and to represent. And she was just going to share some thoughts. She did provide us a document for us to share on the screen, which Libby will pull up in just a moment. And then Rahel, are you here? We're going to give you, we'll have about 10 minutes, and then we can open it up for further discussion with the full set of teams as well.
Yes, can you guys hear me?
Oh, there's we got some reverb. Let's see what we can do. Go ahead, Rahel, speak again, and then we'll see if we've got you.
Okay, can you hear me?
Perfect. Go right ahead.
Yeah. So thank you for the invitation. It's a good framing, you know, the FESAT discussion in a way that one of the things that is very much near and dear to families who are trying to access care and organize the care for their child is the services that we provide for children with complexity are not organized based on how the family experiences the care. It is actually, unfortunately, is organized by how each different entity, each different clinic understands its workflow and its efficiencies, etc. So we have been trying to create what we are calling a clinically integrated network. It is a seamless process by which care is accessed and delivered to families. And one of the two big areas for clinicians were first really make the primary care medical home the central place where families and their primary care provider are partnering to really figure out holistically what the needs of this child are, and then enable the primary care provider to actually have more substantive role to play in making sure that this is done. Now, most of the children who are seen in our clinic have a large number of subspecialists, anywhere from 7 to 10 specialists. And because of the fragility of their medical conditions, also spend quite a bit of time in the hospital. So how do we work together with the inpatient team, with the different subspecialists, and integrate whenever possible, collaborate when integration is not possible, to make the experience for the families as seamless as possible. And as part of this CoIIN, we started approaching this issue, and we learned very quickly in our first approach to our different subspecialist partners that there are different approaches needed depending on what the subspecialist team is. So there are medical subspecialists where once a diagnosis is made, the specialist really has to provide us with just a plan of what the child is supposed to do on a day-to-day basis to stay well, and what they should do on days when the child is unwell or sick from infection, etc. Those subspecialists can pretty much delegate a lot of the implementation of the care plan to the primary care doctor. And we have started this collaboration with the pulmonary department and with the behavioral health. The behavioral health it's called a consult liaison service, where we have a first level intervention that we ourselves start, and if those don't work, then the second level consultation to the psychiatrist, who would then hand back for us to continue the implementation after 3 or 4 visits once things are stable. But then there are other specialties where this is not at all possible, where the work that needs to be done is outside of the scope of the primary care provider. So the eye exams that the children have to have every year or twice a year, the injections for spasticity that they have to receive from the physical medicine and rehabilitation doctor, and some of the referrals that we have to go do to the orthopedic surgeons for spine surgery, for hip surgery. Those ones, we created a collaborative, co-located service where the PM&R doctor comes every other week to do the procedures, and the families will get any other services that they need from us at the same time, whether it's immunization or nutritional consultation, whatever. The work with the orthopedic surgeons is slightly different. We meet with them twice a month to review x-rays and find out which children are ready for referral, so families don't waste their time at orthopedic surgeon offices when they're years away from needing any surgery. And then doing the nutritional and other preparation that will lead to better clinical outcomes. So we're working on protocols and collaborations. Then there are some multi-specialty service lines with which we just do case reviews once a month to review the children. So this is just to say that there is no single collaboration, co-location, or integration that works for all specialties. And there are different ways we are grappling with this. With the inpatient team, where we've landed is we now have a complex care team that is a subset of the subspecialists, the hospitalists, who our children get admitted to, and every morning we have a huddle with them for 15 minutes or so to review all of the children from our clinic that are being cared for in the hospital. So this is a beginning of trying to just grab this octopus and somehow streamline these different things and repurpose the culture in a way that is focused around the family's experience of care and not each discipline's workflow. The challenges, if I could address that bullet now, is this is considered to be a small subpopulation for each subspecialist. 90% of their patients are not this complex. So they have created workflow where all of their patients go through, and there is always a challenge to just change it for these few patients, 10% of patients that they're taking care of. And then the biggest challenge is that there isn't a support infrastructure to actually do this at a systemic level. You can have relationships that we have built with all these subspecialists, and many that are willing to do things outside of their normal workflow to make this work, but there isn't an EMR that allows for a group documentation, for instance, a multi-specialist documentation in one visit. The systems are pretty different and separate, and there is double documentation that doesn't make sense. There are cultural barriers because primary care providers had stepped out of this space and left a lot of the work to subspecialists. It's a culture change to us, the subspecialists, to be the consultants again and put the plan of care for us to implement. And there's been significant improvement in that regard with our, collaboration and relationship building. And the biggest challenge for all of this is the fact that the payment is really not integrated. Some of the case reviews that we do, the huddles that we're doing with the inpatient team, the time that's spent on all of these is not paid for. It is done by providers that get better satisfaction from having a seamless integrated care delivery system, but the payment incentives are really not aligned to support this kind of work. So what we need and the lessons we're learning from these collaborations, and I'd like to say the last slide that was shown earlier is like, don't wait for a perfect system, just go try some things. We have bravely started a whole lot of things that we don't know how they're going to be sustainable, but we have started this collaboration with the behavioral health and with the PM&R doctors and with cardiology, with the inpatient team, and with the hope that there are going to be lessons on how a clinically integrated system would work, what documentation, what single assessment would work for all of them, instead of subjecting parents to filling more information from a clipboard in every waiting room of every specialist asking the same questions, and what kind of systems could hold a lot of the fundamental information to just be used by multiple providers. At the end of the day, we feel that a pilot for a complex care, accountable care organization where there is a system transformation with well-defined processes and collaborations and IT integration and with shared outcome and accountability to all of the players, which would ideally be led and designed in collaboration and with leadership from the parents who are experiencing the care at the ground, is probably the way we feel that these efforts will be sustainable. Maybe I'll just stop here and address any other questions if they come up. I have many members of the Texas team here with me, and I just want to offer, if Sherry, Marianne, maybe Ivy's on the line as well, have anything to add to that?
One of the other things that we jumped in and just started doing from the family aspect is we're trying to get a inpatient family support group going, and we're trying to figure out how we can make sure that the inpatient families know that the clinic is still here for them. That's one of the things that I was trying. And then last week we decided to add a chance for me to meet the families actually in their hospital room, especially the families that we knew were going through some major life change, such as visiting with palliative or hospice. How could I, as the family liaison, support that mom emotionally, even though they were there at the clinic? I mean, they're at the hospital.
Hospital.
Yeah, they're at the hospital, but how can the clinic support them even during that hospital stay?
Anyone else from Team Texas want to say anything before we open it up? Very good. I do, just along that last point, I do know of other models. I know in spinal cord injury with adults that they have a clinic set up. It's actually affiliated with a hospital system, and they're able to go in and work within that hospital system whenever one of their outpatients is admitted. And I have here in the comment box from Debbie Harris, I love the idea of having an inpatient complex care team as a subset of the hospitalist. So, and Kara she says, thanks for your sharing a tremendous work, Team Texas. You balanced the challenges and aspirations, did such a great job sharing in images. Dancing with and wrangling with an octopus. That's quite an image. And well, we're all going to walk hand in hand and hand in hand and hand in hand in hand with octopus, however many hands that is. So I guess that I want to see if anyone else has any other questions for them about what they're doing, or anything else that you'd want to probe deeper to just understand, or any feedback. Okay. So we're very grateful for you just sharing as you were saying, you're really bravely going forward with this. I think that's one of the things that we're trying to allow the CMC CoIIN to do. This is the first time for HRSA's been able to really focus on CMC, and so that's allowed this groundswell of motion and movement together around it for lessons learned. So and again, perfect not being the enemy of the good. So I think what I'd love to do is for us to move to the next slide and see what other teams may want to share, to see what we can, again, in this learning lab together, have an opportunity to look at and help move your work forward while we have a host of a panel of people available, including your peers, to be able to provide input. So if anyone has anything else, I want to open it up to everyone, or even Team Texas. If there's something in particular you want to ask your peers about while we're all together, given that you just spotlighted your project, we'd love to have you do that as well.
This is Team Texas. We just want to learn from others.
Great. Thank you. We did just get Mary Jo popped in a few of the a few links that were being requested earlier that are active links, so folks wanted to look at those. So maybe if we could, Libby, move to the wheel, and we'll try spinning again to allow people the opportunity to share a little bit from their particular work. If we get Alabama or Washington, we'll start again. All right, we've got Wisconsin. We have someone on the line from Wisconsin that will share a little about where you're at with interprofessional collaborations within your team's work.
Hi, this is Tara Bartelt from Wisconsin. Can you hear me?
Tara. Yes.
So yeah, we have, I guess our team has evolved over time. We work with American Family Children's, our children's hospital in Milwaukee, and now recently we've just joined with Marshfield Hospital, along with Title V, the Bureau for Child Services. We've recently added a member of that team as we've been working a lot on increasing waiver availability to our patients, and so that was a really great add. And then some of our regional resource centers, we have people from those teams. So as our project has evolved, we've been lucky to be able to bring on different members of the team from various locations from across the state. And then recently we also have some medical home grants within the state that Title V sponsors, and Sharon can talk a little bit more about that if she's on the phone. But so we've taken the two other groups that are doing Title V work for their shared plan of care and transition, and they have joined our team as well, so we can all work together on some of our shared plan of care work that we're doing in the next year around goal setting. And then have been really working hard on goal setting along with the waiver service coordinators and things like that. So we use the FESAT, when we did our FESAT tool, we recognized that bringing on new members, we needed a better explanation of what we've been doing and where we're going. And so we've put together sort of a welcome pack that our family members helped with, and various members of our team to onboard new people so we could sort of start at a level playing field, I guess. So I think bringing on new folks and having them sort of jump in the middle can be challenging at times. So that's been the work we've done so far.
Thanks.
Yep. This is Sharon. I'll just jump in. Can you hear me?
Yes.
Okay, great. So thank you, Tara. I just would add that, you know, if we were in a little different place because a number of the clinical sites at American Family and at Children's, and Tara and Mary and that group had worked together on a CMS funded grant. So started out, but really have built the team to include, and I know Barbara's on from Family Voices. All of our clinical teams have really great, strong family representation. It feels like a really fun collegial group. I think the part that we're working on is, as well as talking about the waiver piece that Tara mentioned, is really looking at how can we build the diversity of our representation so that the families that are part of our team represent the families that are part of the complex care programs as well. So that's our next challenge as well. So thank you, Tara, and everybody.
Thanks, Sharon.
This is Ivy. If we have a minute, I have something.
Absolutely.
So I'm on Team Texas, and our focus was on interprofessional collaborations clinically. Yeah. But if we can pull back a little, and I'm not at the same location as Dr. Burhani and Sherry and the rest of the team, so we can't look at each other, but another direction on interprofessional collaboration is how the CoIIN has helped bring together and build interprofessional relationships in such significant ways. Of course, there's our state Medicaid folks that, you know, Dr. Burhani had connections with through a work group that she's on focused on children's managed care Medicaid services. But I think the CoIIN was really the impetus for strengthening those relationships and making them more meaningful. We've grown as a team and strengthened the expanded interprofessional relationships with other comprehensive care clinics, health plans. We have a very strong relationship with one of our MCO partners. And also, Sherry Santa was our official family representative when we started on the team, working, and she's with our Family Voices affiliate, Texas Parent to Parent. But when she described now building a family work group with families in the hospital, with clinic families, going to visit them, that's because her role has changed, and she's part of the clinic team officially now, also, in addition to her work with Texas Parent to Parent. And I just think, I know that we're also grateful for the CoIIN because it allowed all of these relationships to evolve and strengthen. I don't know if anybody on our team wants to add to that, but it's just an interprofessional collaboration that I wanted to point out, in addition to the clinical ones that are, you know, building and growing.
Yeah, Ivy, thank you for bringing this up. I think we focused on sort of straight at the point of care where care is experienced by families. But if you look at organizationally, what has happened to the CoIIN from the time we started to where we are now, it's a huge growth, and we have been able to engage through our monthly lunchtime meetings, other complex care provider medical directors, one in San Antonio, a health plan in Lubbock that takes care of more of the rural ones that we were not really addressing here. We have now a leader of a very innovative FQHC in our town who is also joining the CoIIN. And we are thinking about maybe expanding a couple of other individuals, one a Value Institute, to help also think about how we do that. So the team has grown and expanded. It's involved a lot of innovative work around this population. Even the members of HHSC team that during our monthly meetings have increased from quality departments, medical director's office, etc. So it's been a good convener, and it has led to the creation of sort of a group that meets together and thinks about how the system needs transformation.
And one of our family work group members has also transitioned to being on our core team also. And she attends things like this webinar and has really stepped up as a family leader. So we're even doing more family relationships.
Yeah, that's great. Tamara Bickel had a question. Tammy, what format are your monthly meetings? Webinar, phone, some in person? How do you do that?
Yeah, I think we have, again, we serve lunch. We get catered lunch. So we house them in person at the clinic, and we encourage people who are able to come. It's an hour and a half. And we have also Zoom for people who are not able to come. So some of the people who are out of town, the San Antonio partners, and people who are far, even within the city, join by phone.
Great.
And our family member on that team, and any family member that we invite, does get the compensation that we have made sure was in place from day one for all participating family members.
Great.
When we started this campaign, we started maybe the first year or so meeting twice a month. But as implementation pieces unfolded, we pulled back to meet as a full team to once a month so that the clinic team could meet and actually, you know, do all the things we
Yeah, that makes sense. So that is
Institute, for those who don't know, is through our medical school, Dell Medical School.
Right.
Say it again, the what institute?
Value Institute for Health and Care at Dell Medical School has been a great partner to us. And, you know, I never knew who they were, and it's our medical school, right? And so now Title V, you know, the connection, it's really, and I'm guessing that for all of, at least a lot of other state teams, the relationships have grown exponentially.
Yeah, and that's good to hear, and that's something that we can continue to discuss and harness as we move forward in the project, and good to be able to share out those learnings. I'm wondering, Renee has joined us, and Gary's here too. I don't know if, and Renee had a slide of just a good example of exactly the kind of thing that you're talking about for real world strategies in relation to trying to look at lasting policy change as an end goal that we thought would be nice to just share out briefly. Renee, are you there and ready to be able to do that?
Hi, yes, I'm here. Can you hear me?
Yes.
Thanks for inviting me today and enjoying this webinar. So this is actually a brief overview slide of some of the work that happened in Pennsylvania a number of years ago that I think might emulate some of the work that a lot of the various state teams are doing and thinking about. So my Venn diagram, I think, it'll come to life maybe perhaps when I tell you this story. So a number of years ago, a partnership that really ensued with the Philadelphia Department of Public Health at one of their work group meetings for families of children with special health care needs. One of the parents that was there, as we were talking about various issues families were encountering, talked about the challenges she was having with transition. And I very vividly remember being at that meeting where she described the transition process as falling off a cliff, and just wondering, you know, with all the folks in the room, and in the room at this particular meeting included clinicians, community partners. There happened to be someone there who was representing Medicaid at the state level, even though it was local, and folks were there. Several youth representatives were there, and a variety of community stakeholders and partners. And the director of the group, who happens to be a social worker, at that recommendation convened a work group that proceeded to meet over the course of about a year, kind of looking at what were some of the challenges related to transition to adult-oriented systems, and sort of thinking about very pragmatically what were some of the things that we could do together as a team. And one of the things that came out of that work group was something called the Transition Policy Managed Care Operandums Memo. And it has had various iterations of the name, but this particular policy that came into being just about 9 years ago when it was official, took several years to operationalize, but really came out of this work group that in essence this policy allows pediatric clinicians in the Medicaid sector to have overlapping visits with adult primary care providers for youth with special health care needs that are transitioning. And because one of the things that really was drilled down in this work group over the course of time, and there were various projects and pieces that came out of it, but this was one that I really wanted to highlight for this group because I really thought that it emulated just about having, you know, it wasn't like even the head of Medicaid that was in this work group. It was someone who was on the managed care side that met with us and met with families. And really there were representatives from each of the circles that you can see there in my Venn diagram. There's about 15 of us that became part of this work group. And this was one of the long-lasting policy changes that came out of it. And I think one of the reasons why I love this example also is that it really did, the inception of it really was inspired by a family suggestion and their experience. And it was a lived example that many families and other folks agreed with. I mean, we had done a little bit of a sort of small informal focus group and survey. But the key, I think, in all of this was just bringing partners together. And I think when I think about a lot of the policy folks, there were folks that were there from the Department of Health, both at the state and district level, and you know, having that the clinical voice as well as the family voice and the youth voice there with various stakeholders. I think, you know, it really exemplified a way to kind of put some policy into place. And we really hadn't tested the policy. I mean, Medicaid and the folks that were there and when this was brought up really felt like this was a very important thing to try to do. And, you know, as opposed to other policy changes that sometimes you have to have all this data to get things, you know, to move forward. It was really a big learning experience for many of us to say something that sort of makes sense, that doesn't necessarily cost the system any more money, but really this policy still is in effect today. And I really attribute the success of getting this through to the folks that were at the table, coming together, and you know, it didn't happen overnight. Certainly took time, but it was folks really listening and really, you know, thinking about all the various things that could happen. So that was one of the examples that I wanted to share. And I don't, you know, a couple other things came out of that, but this was the one that I really thought I wanted to highlight for this group.
Thanks, Renee.
Sure.
I don't know, any other comments on that or questions? Yeah, there's questions about the policy itself. So one is, I was wondering if you'd be able to post a link to the policy. That occurred to me too. And Sherry is wondering if that's a statewide policy.
Sure, yeah, I can send you a link to the actual operandums memo. And yes, it's statewide. And so it came down from the, like this, for us, you know, in Harrisburg, came down from the state Medicaid office. And as many of you know, as I'm probably similar in other states, is that some things are mandates and other things are like suggestions that, you know, various Medicaid managed care companies can sort of take under advisement. And one of the key things about this particular operandums memo was that it came down as a mandate, meaning that every of the MCOs, managed care companies across Pennsylvania's Commonwealth had to operationalize this. Interestingly, one of the things that we found over time, you know, there's hiccups, and that's where I think coming together, we realized there was one Medicaid managed care company that operationalized the definition of what a child with special health care needs really meant differently. In their MCO, they felt that children with special health care needs, and for this particular operandums number, they only wanted it to apply to children with home nursing. And at which case we had gotten feedback from a practice as well as a family member about that more stringent definition. And, you know, we very amicably kind of talked about it and got policy folks involved and realized that that was one of the things that we needed to do, is be a little more prescriptive about the definition. And in fact, I still remember the head of Medicaid the medical director, like a very high up person who sits in Harrisburg, saying, I feel that this should apply to any child who has special health care needs, and if a parent thinks their child has special health care needs, they have special health care needs, and that's who should be able to adopt this. But it was an interesting hiccup just for us to, why I think having the group together was a great forum, because it allowed for that like bi-directional communication and feedback after it went into place. So it is still in place. I'm happy to share the link with you that has the actual policy in it. And it's not perfect. I don't mean to make it sound like this was the holy grail that made everything, that transition is perfect in Pennsylvania. But the other thing that it did was really start the conversation. And I think there were a lot of aha moments for a lot of our policy folks and a lot of the case managers at the various Medicaid managed care companies that often aren't as on the ground as the families, youth, and the clinicians are. So I can send that to you, Bethlyn, so you can send it out to the group.
Yeah, that would be great. Thank you, Renee. Are there any other questions or comments from what Renee is saying? We're going to be done soon, but I just wanted to leave room for this while we were in the middle of this piece. Okay. Renee, I appreciate that. So I don't know. I know that, so we were planning on, if we had time, we've been really trying to keep these very flexible, and everyone's been fantastic that's on call to be engaged. Steve, I don't know if you just want to mention your drive home point from your slides that we'll end up sharing later around kind of other ideas for sustainability. Why is it so hard? So we won't have time to go through this whole thing, but we'll get there. Go ahead, Steve, with whatever your drive home point you'd like to make.
Sure. Can you hear me?
Yes.
Okay. Well, we all know that sustainability is very difficult when these grants end for interventions or special innovations. And I think that there are some special challenges that relate to this population and these types of services. And Dr. Bahani had mentioned that integrated payment was one of the pieces that was not in place in Texas, and that was a challenge in terms of supporting the service configuration that they're developing. I guess the drive home point here is that even though there are many obstacles, and these slides allude to them, and the professionalization of advocacy, where there's a government relations person from a big hospital system that talks to policymakers, that talks to the Medicaid folks, especially the Medicaid director and medical director and so forth, that those folks have many, many different interests and are involved in many different issues. And the advocacy and the ability, I think, to drive through the kinds of changes that are associated with the various CoIIN projects, really the most effective advocates for that are the interprofessional team, especially the families and the children and the clinicians who are on the ground, who know what these interventions are, that can describe the population clearly and the impact that they have. And then the professionals can help do the linkage and get you to the right folks and hopefully help to design some policy solutions within the context of what are pretty complicated Medicaid regulations and different ways to develop policy. But I would encourage the notion of interprofessionalism within the context of the payment reform as well. It's not just a technical issue for the finance people and the accountants, and in fact, sometimes that's the worst way to bury it. So maybe I'll leave it there.
Thank you, Steve. That was perfect, and please know that Steve has been really considering ways we can help frame this for you all. So we'll be able to do that. We're going to drop to the end of our time here, and I apologize. Gary was here with us too, and Gary, if you have any other thoughts you'd love to share, we can put those in our follow-up email. And please move to, we'll just send this out as part of the email. Libby, if you could move to the evaluation link, please. That's great. Thank you, everybody, for your time today. We really appreciate it. Gary, anything you want to say?
Thanks. I was just typing everybody that I think it's great work, and I'm not sure that I had a whole lot to add, but I'm happy for if anybody wants to email me offline with any questions or anything, particularly about the accountable care organization world, which we're pretty heavily involved with. thanks for everybody's great work.
Thank you, Gary. And I see if anyone has anything else they'd like to drop in the chat box, that will also give us a record of that to be able to share out with others. So we'd love to have you do that as well if you have anything else. And Gary just dropped his email in so you can see that. Great. Thank you, everybody, so much for your time, dedication, effort every day. So we are going to end, but we're going to leave this open for a few minutes so that we are letting you have the opportunity to do the evaluation now. If you'd like, we'll also be sending a follow-up email. Thanks again, everybody, and take good care. We'll be in touch soon. Also, while we're still here, if anyone wanted to mention anything to us directly, we're more than happy to chat with you privately or stay on, hop on another line to talk for a few minutes if anything else came up during this webinar that you'd like to follow up on immediately.
Team, I think it's okay for us to log off now as soon as you're ready. Thank you all very much for your terrific work in putting this together. I think it went really well. I think we had a little bit too much content for the time that we had available, but leave them wanting more, right? It's like leaving a party before you're tired of being there. So thank you all again. Talk with you soon.